Hello, everyone, and welcome to our module on the brainstem. Before we get into the brainstem, let me quickly review some anatomic terminology that you need to understand. So when we say that an anatomic structure is dorsal, we mean it is posterior or located towards the back of the body. In contrast, when we say a structure is ventral, we mean it's anterior or towards the front of the body. And then when we say a structure is rostral, we mean it's towards the top of the head. And then caudal means towards the tail, but humans don't have a tail, so caudal basically just means away from the head. Okay, so with that out of the way, let's talk about the brainstem. So this is the brainstem right here in this drawing. It is literally a stem beneath the brain, and it has three major regions: the midbrain, the pons, and the medulla. The pons you can identify because it sort of bulges out and it's a little bit bigger than the midbrain, which is above the pons, and the medulla, which is below the pons. And hanging off the back of the brainstem, that's where you find the cerebellum. And over here on the right is an MRI image, and the structures of the brainstem are fairly easy to see by MRI, so you should get familiar with them. You can see this bulge right here in the brainstem, so that's going to be the pons. That's going to make this the midbrain above it, and that's going to make this the medulla down here below. And then this all feeds down into the spinal cord in the back. So if you took the brainstem and you made slices of the three major regions, they would look something like what you see on the slide here. This is what the midbrain looks like, this is what the pons looks like, and this is what the medulla looks like. And what we're going to do in the rest of this video is spend a lot of time looking at these three different regions and talking about the cranial nerves and the motor and sensory tracts that are found in each section. But what I want to point out to you on this slide is just a general appearance of each section, because one thing you have to be able to do is just know what section you're looking at when you see one of them. So first of all, if you look at the midbrain, it has this funny appearance like a couple of dog ears sort of hanging off it right here. And then it always has this little circle near the back, near the posterior dorsal region. That's the cerebral aqueduct. The pons and the medulla both have the fourth ventricle as part of their structure, so I'm marking where the fourth ventricle is right here. And then the pons is a big section of the brainstem. Remember, it sort of bulges out in those images that we saw, so it's always going to be a larger picture. The medulla is a little bit smaller. And then one characteristic feature of the medulla is it always has this funny region down here. This is called the inferior olivary nucleus. It's actually not entirely clear what role this plays in the nervous system, but it's such a striking feature. It's one of the easiest things to identify to know that you're looking at the medulla. When you see that in the fourth ventricle, you can be sure you're looking at a section through the medulla. A lot of what we're going to talk about in this video is what happens when you have lesions of various regions of the brainstem, and a very common cause of a brainstem lesion is a stroke. So let's talk about that in general now for just a second. So first of all, you should know that brainstem strokes are much less common than cortical strokes. In other videos, I talk about cortical strokes like MCA strokes. Those are far, far more common than brainstem strokes. You should also know that patients who are having a brainstem stroke will lack cortical signs. These are signs that the cortex is involved. They won't be present in someone who is having a stroke isolated to the brainstem. So what are some of the cortical signs? Well, first of all, aphasia, like Wernicke's or Broca's aphasia, which I explained in other videos. That's a cortical sign. It tells you that the stroke involves the cortex, not the brainstem. Spatial neglect, which is caused by ischemia or stroke to the sensory cortex. That's also a cortical sign. If you have damage to the frontal eye fields in the frontal lobe, that will give you left-right gaze deviation, which I talk about in other videos. That's another cortical sign. And then finally, visual field defects like homonymous hemianopia and quadrantenopia. These are all caused by damage to fibers that run through the cortex. And I talk about these defects in videos in the ophthalmology section. But just be aware that in a question, if you see these things here, then they're describing a cortical and not a brainstem stroke. If none of these things are present, then they could be talking about a brainstem stroke. Another thing to know about brainstem strokes is that they cause so-called dense hemiparesis. So what does this mean? This means that with a brainstem stroke, patients can present with paralysis on half their body, and the paralysis will equally involve the face, arms, and legs. That's dense hemiparesis. In contrast, if you have a cortical stroke, for example, a stroke involving the MCA territory in the cortex, that will present with hemiparesis, but it will be more pronounced in the face and arms compared to the legs. That's because of the way the motor cortex is designed up in the cortical region. In contrast, if you have an ACA cortical stroke, this will present with hemiparesis where the legs are affected more than the face or arms. So this sort of differential effects on the face and arms compared to the legs, that suggests a cortical stroke, whereas dense hemiparesis suggests a brainstem stroke. Another thing you need to understand about the brainstem in order to understand brainstem strokes is the blood supply to the brainstem. So let's talk about that now. So we broadly divide the blood supply to the central nervous system into the anterior and posterior circulation. The anterior circulation refers to structures that receive their blood flow from the internal carotid arteries. So if you look at this drawing over here on the slide, which I go through in great detail in other videos, these are the internal carotid arteries right here. And they're going to supply blood to this whole region up here. That's the anterior circulation. And the blood in that region supplies structures in the cerebral hemispheres, like the frontal lobe, the parietal lobe, and some of the temporal lobe. It also supplies other structures near the cerebral hemispheres, like the basal ganglia and the internal capsule. And so the two major blood vessels that can be involved in strokes of the anterior circulation are the anterior and middle cerebral arteries. This is the middle cerebral artery shown right here. This is the anterior cerebral artery shown right here. They make up the major blood supply of the anterior circulation of the central nervous system. In contrast, the posterior circulation is all this blood supply back here. It comes from the vertebral arteries, which are shown here, and also the basilar artery, which is this artery running down the middle. The blood supply back here delivers blood flow to regions like the brainstem, which we're going to talk about in this video. Branches of the posterior circulation are what supply all those regions of the brainstem we just talked about. Posterior circulation also supplies the occipital lobe, the cerebellum, the spinal cord, and the thalamus. And so you will hear talk, especially in clinical circles, of the anterior versus posterior circulation, especially related to strokes, and this is what they're talking about. Okay, so now let's talk about the blood supply to the brainstem. It's all going to come from vessels in the posterior circulation back here. And in this drawing on the slide here, the midbrain is sort of high up, the medulla is down at the bottom, and the pons is in the middle. And so we'll start by talking about the blood supply to the midbrain. It's going to come from vessels in the posterior circulation that are higher up, and the main vessel that supplies blood to the midbrain is the posterior cerebral artery shown here. Now we move down to the pons. It has a different blood supply depending upon whether you're talking about the medial or midline pons or the lateral pons. The medial pons gets its blood supply from these vessels right here. These are called pontine branches of the basilar artery. The lateral pons, on the other hand, gets its blood supply from branches of this vessel right here, which is the anterior inferior cerebellar artery. Moving down one more notch in the brainstem, we come to the medulla. And so the midline of the medulla gets its blood supply from this vessel right here, which is the anterior spinal artery. That does supply blood to the spine, which I talk about in other videos, but it also supplies blood to the medial medulla. And then the lateral portions of the medulla are going to get their blood supply from this vessel right here, which is the posterior inferior cerebellar artery, or the pica. Okay, so now that we've gone through all that, let's go through the important structures found in the different regions of the brainstem. And we'll start at the top of the brainstem with the midbrain. So shown on the screen is my own drawing of the midbrain and the key structures. Once again, the cerebral aqueduct is this small little circle right here. This is the dorsal or posterior portion of the brainstem, and over here is the ventral or anterior portion of the brainstem. So key structures that you find here, first of all, the spinothalamic tract carrying sensory information on pain and temperature is shown right here. And then the medial lemniscus is right here. This carries sensory information from the posterior columns of the spinal cord. This is sensory information on vibration and proprioception. These long sort of spider-like fibers here are cranial nerve 3, the oculomotor nerve. And then this small structure right here is the medial longitudinal fasciculus. I talk about this a lot in videos in the ophthalmology section. It helps coordinate lateral gaze. And if you have damage to this structure, you get a clinical syndrome called an intranuclear ophthalmoplegia, which I talk about in other videos. And then down here on either side, we've got these big structures sitting off the end of the midbrain. Those structures are called the cerebral peduncle. And within the cerebral peduncle, you find this region right here. This is called the crus cerebri. And this carries motor tracts, upper motor neurons of the corticospinal and corticobulbar tract. And so damage to this region right here is going to create motor findings. And then this slide shows another drawing of the midbrain, this one from a textbook. It shows the same structures that I showed you in the last slide, just with a little bit of a different appearance in the drawing. Once again, this is the cerebral aqueduct right here, so you know you're looking at the midbrain. This is cranial nerve 3. Corticospinal tracts are over here. This is the substantia nigra. It's part of the basal ganglia that I talk about in the videos on the basal ganglia. It's found in the midbrain. This structure right here, you've got one on each side. That's the red nucleus. I'll talk more about this in a second. It's important for fine-tuning motor movements. And then finally, in the back here, the dorsal side, you've got these two little bumps. These are called the superior colliculi. And they're important because when you grossly look at the brainstem, you can actually feel these little bumps. And so they're often pointed out in cross-section like this picture on the screen. Let's talk in a little bit more detail about the red nucleus. So as I've already mentioned, it has a limited role in motor control. It sends fibers out via a minor pathway called the rubrospinal tract. But one of the most important things to know about the red nucleus is that it's a key landmark in patients with severe central nervous system injury. So when patients come into the trauma bay with a severe head injury and they're unconscious, You can tell whether their injury is above or below the red nucleus based on certain clinical findings called posturing. So let's talk about that now. So to understand posturing, you have to appreciate that the cortex, our upper brain, like the frontal lobe and the temporal lobe, it's always sending inhibitory input to the brainstem. So if you get a lesion above the pons in the brainstem, like a massive bleed above the pons, this inhibition will be lost. And when this happens, the patient will resort to primitive reflex patterns, and those patterns are called posturing. Posturing is an involuntary motor response to a stimulus. Often it's a sternal rub of an unconscious patient in the trauma bay. You rub their chest, you rub their sternum, and you will see a motor response. That's called posturing. This only happens with severe brain injury. It's usually only appreciated in patients who have lost consciousness from a massive intracranial injury. So there are two forms of posturing you can see. The first is called decorticate or flexor posturing. This happens when the patient has a major CNS lesion above the red nucleus, somewhere in the cortex or the internal capsule. What's going to happen is when you rub on the sternum, the chest of that unconscious patient, they're going to flex their arms and extend their legs. It's going to look like this picture right here with the arms flexed over the chest. The other type of posturing is called decerebrate or extensor posturing. This happens when there is a major central nervous system lesion below the red nucleus, somewhere in the midbrain or the upper pons. When this type of posturing occurs, you'll rub the chest and the patient will extend their arms and legs. It'll look like this picture right here with the arms extended. And then if the lesion is even lower than that, like let's say there's a massive brain lesion in the mid-pons or somewhere below that, then there won't be any posturing. The patient will just have flaccid paralysis. They can be in a coma, they can have respiratory arrest, but they won't have this decorticate or decerebrate posturing. So this is probably the most important thing to know about the red nucleus, is that you can localize lesions to above or below the red nucleus based on the type of posturing an unconscious patient demonstrates. Okay, so now what I'm going to do is talk about a couple midbrain syndromes that occur when there's a lesion of the midbrain. And we'll start by talking about Benedict syndrome. So Benedict syndrome is a midbrain stroke syndrome. It's associated with stroke involving branches of the posterior cerebral artery. Remember what I told you before, the PCA is the major blood supply to the midbrain. It involves the tegmentum of the midbrain, which is the central portion. Generally, Benedict syndrome occurs when there's a stroke involving this region shown in blue on the slide right here. So what's going to happen when there's ischemic damage to this region here? Well, first of all, remember cranial nerve 3 is running just like this. So you're going to lose cranial nerve 3. This is going to lead to an oculomotor nerve palsy, which presents with the eye down and out. You're also going to have damage to the medial lemniscus, which is right here. This is going to cause contralateral sensory loss. So proprioception and vibration sensation will be lost on the opposite side of the body compared to where the lesion is. And then finally, you're going to have damage to the red nucleus right here. As I told you, that's important for fine-tuning movement. So when it's damaged, you get involuntary movements like tremor and ataxia. Our second midbrain stroke syndrome is called Weber syndrome. This is a ventral midbrain stroke syndrome. And remember, ventral means anterior. So if you look at this image, this is the anterior region. This is the posterior or dorsal region in the back here. Weber syndrome is an anterior stroke syndrome. It involves this region down in here. It is also caused by stroke involving branches of the posterior cerebral artery. And what's going to happen when you have damage to this region down here is you're going to get some of those cranial nerve 3 fibers. And once again, you will have an oculomotor palsy on the side of the lesion. Also, you will damage the corticospinal tract because it's running out in this region like here, as we talked about. That's going to cause contralateral hemiparesis. And then finally, patients will develop contralateral lower facial droop. So why does this happen? This occurs because of damage to the corticobulbar tract. Remember, the corticobulbar tract runs in this region right here, and it has upper motor neurons that supply the cranial nerves lower down in the brainstem. And so the lower facial droop is caused by an upper motor neuron lesion involving cranial nerve 7, the facial nerve. The reason the facial droop is only in the lower face and not in the forehead is because the upper face, meaning the forehead, has bilateral upper motor neuron innervation of corticobulbar tracts on both sides of the body. So the corticobulbar tracts on this side are going to be healthy, even though the ones over here are damaged. And these corticobulbar tract fibers are going to continue to supply innervation to the forehead. So you won't see droop of the forehead, only lower facial droop. You also won't see upper motor neuron lesions of other cranial nerves besides cranial nerve 7. That's because most of the other cranial nerves have bilateral innervation. So losing the corticobulbar tract on one side does not affect them. Okay, and then our final midbrain syndrome we'll talk about is Paranode syndrome. This is a dorsal or posterior midbrain syndrome. It occurs in this region back here. This region is called the pretectal area, and it's near the superior colliculi. Remember, these two bumps are the superior colliculi. So the word tectum means the roof of the midbrain, and the colliculi are these two rounded structures. And so Paranode syndrome involves the pretectal area, which basically means the region of the midbrain just below the top of the midbrain. This syndrome usually is not caused by stroke. Instead, it's usually caused by compression. There are a couple of things in this region that can compress the midbrain. One is the pineal gland is very close to here. So if you get a pinealoma or a germinoma, these are rare tumors involving the pineal gland, they can compress this region right here. Also, the cerebral aqueduct is right here, as we've discussed. So if there's hydrocephalus involving the third ventricle, the cerebral aqueduct can enlarge, and that can also compress this region, causing Paranode syndrome. So Paranode syndrome has a very unusual collection of features. Damage to the pretectal area damages the region of the midbrain that controls the pupillary light reflex. There are neurons found in this region here that project to the Edinger-Westphal nucleus, which I talk about in detail in videos in the ophthalmology section. So when you get damage back here, you lose the pupillary light reflex, and this presents as so-called light-near dissociation. This means that the pupils will not constrict in response to light. They can't because the fibers that would manage that are destroyed here. But the pupils will constrict when you move a finger or another object near to the nose. They will be able to accommodate. This is sometimes called a pseudo-Argyll-Robertson pupil because you can get this same finding in neurosyphilis. It's called an Argyll-Robertson pupil. And this looks just like that, but it occurs in patients who don't have syphilis. That's why it's called a pseudo-Argyll-Robertson pupil. And then the other thing found in this region in the back of the midbrain are vertical gaze centers. These are nerve fibers that coordinate upward gaze so that both your eyes look up or down together. So when you have a lesion back here, the patient won't be able to look up. So Paranode syndrome pulls the eyes down and causes pretectal problems. This is the mnemonic some people use to remember these odd clinical features here. And so shown on this slide is a summary of the 3 midbrain syndromes we've discussed. These are the key findings here that you want to be familiar with so you can recognize these syndromes in a board question. And once again, remember, in a midbrain syndrome of any cause, there will be an absence of cortical signs telling you that this is not a syndrome involving the cerebral cortex. Okay, so that's the midbrain. Now let's move on and talk about the pons. So shown on this slide is my own drawing of a cross-section through the pons. The pons looks a little bit different depending upon whether you're looking at a section that's higher up or lower down, but this image is designed to give you a general idea of where the major structures in the pons are found. So first of all, this is the fourth ventricle back here. When you see that, you know that you may be looking at the pons. There are 4 cranial nerves found at the level of the pons: the trigeminal nerve, cranial nerve 6, cranial nerve 7, and also the vestibular nerve, cranial nerve 8. And I've shown their locations on this slide. Corticospinal tracts on either side are found here near the midline. Same thing for the medial lemniscus. It's found right here near the midline, carrying information about proprioception and vibration. And then just outside the medial lemniscus is the spinothalamic tract. Also notice up here, you have the medial longitudinal fasciculus. Those are these 2 little tracts right here. And also the PPRF. The PPRF is the pontine paramedian reticular formation. And so all the structures that we use to gaze laterally, meaning to move both of our eyes left or right, are all found here in the pons. You've got cranial nerve 6, which is important for innervating muscles of eye movement. You've also got the medial longitudinal fasciculus and the PPRF. I talk about all these things in videos in the ophthalmology section, but I just want to point out to you that all these central nervous system structures are found here in the pons. And then here's another drawing of the pons from a textbook. Once again, you've got the fourth ventricle in the middle. You can see all the nerves I talked about on the last slide. I'm just giving you different pictures of the cross sections because on an exam, you may see a drawing that looks a little bit different from another one. You have to be able to find the major structures, and they're all shown here and also on the last slide. Okay, so now let's talk about some stroke syndromes involving the pons. And you can broadly divide stroke syndromes of the brainstem and the pons into those that involve medial structures and those that involve lateral structures. I'll start by talking about what a medial pontine syndrome looks like. So this can occur when there's a stroke involving branches of the basilar artery. If you look at this drawing on the slide, this is the basilar artery, and it gives off these little branches that supply the midline portion of the pons. So if there's a stroke in this region, the middle of the pons, what's going to happen? First of all, there will be damage to the corticospinal tract. This will cause contralateral hemiparesis, dense hemiparesis on the side of the body opposite to the side of the stroke. You will also get a cranial nerve 6 lesion. So this will cause paralysis of the lateral rectus muscle, which moves the eye laterally on the side of the stroke. So patients can present with diplopia. They can also have an inward gaze of the eye on the affected side. Basically, since you lose the lateral rectus, the medial rectus will pull the eye towards the midline, towards the nose. You can have a lesion of cranial nerve 7. It's also found near the midline. This can lead to facial weakness and droop on the affected side. In this case, the facial droop will involve the forehead because it's a lower motor neuron lesion, not an upper motor neuron lesion like we talked about before. And then there will be damage to the medial lemniscus. This will lead to loss of proprioception and vibration on the side of the body opposite to the side of the stroke. And then finally, all those lateral gaze structures I pointed out a few slides ago, like the medial longitudinal fasciculus, the PPRF, the nucleus of cranial nerve 6, those can all be damaged in a medial pontine syndrome. So this can give you gaze palsies. Often it presents as inability to look towards the affected side because of damage to these regions. So if you want a handy mnemonic for a medial pontine syndrome, some people use CML for contralateral weakness, medial lemniscus involvement, and lateral gaze palsy. The other broad category of stroke syndromes in the pons are the lateral pontine syndromes. These occur with infarction involving the anterior inferior cerebellar artery. If you look at this drawing on the slide here, this is the AICA. It's coming out and supplying blood to the lateral region of the pons. So damage or ischemia of this vessel can lead to damage to the lateral pons. So what's going to happen when you get lateral pons damage? First of all, the spinothalamic tract is a lateral structure in the pons. It will be damaged, and this will cause contralateral loss of pain and temperature sensation. Cranial nerve 5, the trigeminal nerve, also has its sensory nuclei located laterally in the pons. So damage here will lead to ipsilateral, same side as the stroke, pain and temperature loss. So get familiar with this pattern. The pain and temperature loss will be ipsilateral to the side of the stroke for the face, but contralateral for the rest of the body. You can also get damage to the facial nerve nucleus. This will lead to ipsilateral facial droop. It will involve the forehead and the entire face because it's a lower motor neuron lesion. You can also lose the corneal reflex because you need the facial nerve for that. And then the vestibular nuclei are found in the lateral pons, so damage here can lead to nystagmus, vertigo, nausea, and vomiting. The cochlear nuclei are also here, so you can get deafness. And then last but not least, sympathetic nerve fibers are also found in the lateral pons, so when they're damaged, you can get a Horner syndrome, which I talk about in other videos. It involves drooping of the eyelid and an abnormal pupil on one side of the face. And so on this slide, I've created a table with a summary of the two broad categories of pontine syndromes. Remember, these syndromes will present with an absence of cortical signs, and then we'll have all the clinical features I've listed here. These are all the things I said in the last few slides. And the blood supply to those regions is the basilar artery branches for the medial pons and the AICA for the lateral pons. Before we move on from the pons, let me talk briefly about a basilar artery infarction. So if you look at this drawing on the slide here, this is the pons, and the basilar artery sits right here, and it gives off these little branches, and stroke involving those branches can give you a medial pontine syndrome, as we've already discussed. But if you have a stroke involving the basilar artery itself, what's going to happen is the entire anterior portion of the pons is going to become ischemic and damaged, and that will lead to a clinical presentation known as the locked-in syndrome. This occurs when there's loss of the anterior pons. So what does the locked-in syndrome look like? Well, first of all, there's bilateral loss of the corticospinal tracts. This leads to quadriplegia, complete paralysis of all limbs on both sides of the body. You also have bilateral damage to the corticobulbar tracts. So this leads to loss of motor control of the lower cranial nerves in the pons and medulla. The midbrain, however, is spared. So cranial nerve 3 and cranial nerve 4, which arise from the midbrain, those will be intact. This means that the patient can move his or her eyes and also blink, and the pupillary light reflex is normal, but the patient won't be able to speak. Also, higher functions like cortical functions are going to be intact. This means that the patient will have consciousness. And so this is a very scary syndrome, the locked-in syndrome. Basically, the patient is conscious and can move their eyes and blink and can see, but they can't speak or otherwise communicate. If you've ever read the book or seen the movie Johnny Got His Gun, it's about a soldier in World War I who had this type of injury. So here's a summary of how the locked-in syndrome is going to present. Consciousness is spared, so the patient will be awake and alert and aware. There will be quadriplegia, loss of voluntary movement in all limbs. There will be some cranial nerve loss. Only vertical eye movements and blinking are spared. Speech and swallowing is absent. Patient can't swallow, can't chew, can't speak. Sensory pathways are often intact. They're usually not damaged, so the patient can still feel pain, touch, and things like that. They just cannot respond to this in any way other than moving their eyes and blinking. Okay, so this brings us to the medulla, our final region of the brainstem, and shown on this slide is another of my own drawings giving you a general idea of where various structures can be found in the medulla. So first of all, we've got the fourth ventricle right up here near the top. And then we've got these funny looking squiggly structures, the inferior olivary nuclei down at the bottom. And that's a thing that can help you understand you're looking at the medulla when you see that inferior olivary nucleus. In the midline of the medulla right here, you have a number of very important tracts. So first of all, these are the pyramids, these bumps in the medulla. and that's where the corticospinal tracts run. And so that's why when patients have upper motor neuron lesions involving the corticospinal tract, it is sometimes said that they have pyramidal signs, and those are signs of corticospinal damage, so named because of the pyramids of the medulla. And then in the middle here, you have the medial lemniscus carrying information from the posterior columns. That's proprioception and vibration sensation from the body. Out here more laterally, we have the spinothalamic tract. So damage to the lateral medulla can result in pain and temperature loss from a lesion here. And then this little tiny thing right here is the hypothalamico-spinal tract. This is carrying sympathetic nervous system information. And so I point that out to you because it's found in the lateral medulla. And if you get damage here, that can lead to a Horner syndrome. And then we've got a number of cranial nerves found in the medulla. So over here, we have the spinal nucleus of the trigeminal nerve and the tract of the trigeminal nerve. That's cranial nerve 5. So damage to this region in the lateral medulla can give you sensory loss to areas that the trigeminal nerve innervates around the face. Cranial nerve 12 is found right here. It starts in the midline and sort of comes out in the middle portion here of the medulla. This is the hypoglossal nerve, and damage here can give you tongue problems. This is the nucleus ambiguus right here. It's a shared nuclei that I talk about in the videos on the cranial nerves. It gives rise to a number of different cranial nerves, including fibers of 9, 10, and 11. And you can see that right here. It's giving rise to fibers of the vagus nerve, cranial nerve 10. We've also got the dorsal motor nucleus of cranial nerve 10 found over here. It also supplies fibers of the vagus nerve that you can see here, sort of coming together with fibers from the nucleus ambiguus. And then up here is the nucleus solitarius. That's a shared sensory nucleus. It sends out sensory nerve fibers to a number of cranial nerves, including cranial nerve 10. And you can see right here, it's contributing fibers to the vagus nerve. And then lastly, up here at the top on either side, you have vestibular nuclei of cranial nerve 8. And so lesions here can give you vestibular dysfunction, things like ataxia, nausea, vertigo, vomiting, things like that. And then here's another image of the medulla just so you can get some different images in your mind. Once again, you can see the inferior olivary nucleus, that funny looking structure that I always use to help me know I'm looking at the medulla. This is the fourth ventricle up here. We've got the corticospinal tracts here and the pyramids, and many of the other tracts and cranial nerves that I pointed out in the last slide can be seen here as well. And so just like in the pons, you can break down stroke syndromes in the medulla into those that involve the medial structures of the medulla and those that involve the lateral structures of the medulla. So let's talk about what a medial medullary syndrome would look like first. This can be caused by stroke involving the anterior spinal artery. If you look at this drawing on the slide, this is the anterior spinal artery shown right here, and it gives blood supply to the medial region of the medulla. When there's a stroke involving this vessel, you will first of all lose the corticospinal tracts, which are right here in the pyramids. This is going to cause contralateral hemiparesis, meaning paralysis on the opposite side of the body from the stroke. You will also have damage to this red region in here in the middle. That's the medial lemniscus. So this is going to cause contralateral loss of proprioception and vibration sensation. And then finally, cranial nerve 12 is coming right down the middle here. And so damage there will lead to flaccid paralysis of the tongue. And I talk about this in the videos on the cranial nerves. But when you have a lesion involving cranial nerve 12 on one side of the body, the tongue will deviate towards the side of the lesion. And so some people remember this stroke syndrome by the 3 M's. Motor weakness, medial lemniscus, and medial tongue deviating to the side of the lesion. And then finally, a lateral medullary stroke syndrome is also called Wallenberg syndrome. This occurs when there's stroke involving the posterior inferior cerebellar artery, or the pica. It's what supplies blood to the lateral portion of the medulla that I'm circling with my pen. So what happens when you have ischemic damage in this region? Well, first of all, those vestibular nuclei I pointed out earlier get damaged. This leads to vestibular signs like nystagmus, vertigo, nausea, and vomiting. You also have damage to sympathetic tract fibers. This can lead to Horner syndrome on the same side as the stroke. The spinothalamic tract is damaged, so this causes loss of pain and temperature sensation on the opposite side of the body from the stroke. There can be damage to the spinal nucleus of cranial nerve 5. This is like the spinothalamic tract of the face. So this will cause ipsilateral, same side as the stroke, loss of pain and temperature sensation to the face. And then finally, the nucleus ambiguus, which I talked about, is a common nuclei for a number of cranial nerves, including cranial nerves 9 and 10. That can be damaged, and so this can lead to symptoms like hoarseness and dysphagia. And so a mnemonic that many people use to remember the features of this syndrome, although there are many others, is don't pica a horse that can't eat. This refers to the fact that a lateral medullary syndrome is caused by a pica stroke, presents with hoarseness and Horner syndrome. Patients have dysphagia, so they can't eat. And so here's a summary slide of the 2 medullary stroke syndromes we've discussed. Remember, in any brainstem stroke, including a stroke of the medulla, you're going to have an absence of cortical signs. And then on this table, I've summarized the key clinical findings and the blood supply that causes the medial and lateral medullary stroke syndromes. And that concludes our module on the brainstem.